And we are live. Vikram Talaulikar, thank you for joining me again in the first of what is going to be a sort of, well, let's hope a semi-regular series of keeping people up to date with what's going on in the latest medical research. And you've picked a good six studies that we're going to whiz through here. Tell us why you chose these ones and what you're thinking.
So I think this, as you said, will be a regular feature. We want MREF to be able to give something back in terms of keeping people up to date, what is being published in the world of menopause. But equally, we'll be selecting some studies in the past, which have either been ignored, have not hit the press as they should. And on day-to-day clinical settings, we will sometimes come across patients and we have to do some background research to find out in that particular scenario what best to advise. That often brings up a paper which is relevant. Those sort of papers are exactly what we are going to include going forward. So the aim here is not to be super expert. We're not claiming to be the all-knowing people or that we are the best statisticians in the world. All we are going to do is try and get 10 minutes on discussing a paper, try to get the message out, what it means for women who will be talking to their doctors about menopause, what it means for the healthcare professionals who will be talking to these women, and how the paper makes a difference to the existing knowledge. So let's crack on when you're ready.
Brilliant. All right. And I can guarantee you I am definitely not the world's best statistician. That one, everybody can definitely agree on. Now, this is an interesting one. And people might think, well, hang on a second, what's this got to do with menopause in particular? Because it's looking at oral contraceptives with I have to come very close to the screen so I can actually see this, I'm sorry. Oral contraceptives with progestagens, desogestrel and levonorgestrel, and risk of intracranial meningioma, a nation case-controlled study which was just published in the BMJ recently, 2025. And interesting, because I should have known this a long time ago about hormone receptors meningioma, because my father had one, but I did not know this until recently. So tell us why did they do this? What's it about and what does it mean?
So this particular group has published on meningioma in relation to different progestogens before. This is a series of publications they have done, and they do very intensive analysis, very rigorous, good quality research. As we look through the paper, it's one of the very good set of quality research that we come across. What they're trying to study is, does use of any progestogens increase your risk of having meningioma that needs surgery? So meningioma, being a brain tumor, will need cranial surgery. They're usually predominantly benign tumors, and they're usually affecting women above 65. So most of them will affect women in age bracket above 60. There has been a notification or sort of statement that has been put out by the Faculty for Sexual and Reproductive Health, FSRH in the UK, when the previous paper came out from this group, and also when the new paper has now come out in the BMJ. And if you're a member of FSRH or you follow FSRH, do go and check the statement, because it also explains what the findings mean for the general population and women using progestogen. So this particular one is a case control study, and that looked at about 8,000 women who had surgery for meningioma. It spanned a time period between 2020 to 2023. And what they were trying to study is the two progestogen, the desogestrel, which is used as the progestogen-only pill, and the levonorgestrel, which we also know is a synthetic progestogen. Does it increase your risk of having a meningioma that would need surgery? Now, to kind of give you a little bit of context in the background, if you look at how common is meningioma, if it's above the age of 40, it's about 18 per 100,000. So the overall sort of rate of having meningiomas is very, very low, 18 per 100,000. And if you look at younger women below the age of 20, it's almost 0.1 per 100,000. So it's that tiny amount. So we're looking at very, very small risks here. Nevertheless, important because it's such a commonly prescribed agent when it comes as a POP, progestogen-only pill. In this particular study, they compared these 8,000 women who had had surgery for meningioma to about 89,000 controls. And so therefore, they were controlling in terms of the age, where they reside, the residency, the mean age being about 59 years of the participants in this study. What did they find? So we know previously from their studies that some synthetic progestogens can increase the risk of meningioma. So that's an association, not a causality. So cyproterone acetate, Provera, medroxyprogesterone acetate, normegestrol have been some of the synthetic progestogens previously linked to meningioma. And again, this study links desogestrel to a small association with increased risk of meningioma. But it clears the levonorgestrel. It says the levonorgestrel doesn't appear to be linked. The desogestrel does appear to be linked. And again, if you'll ask me the figures, how many women would need to take desogestrel to then get one tumor? As you
It's
would
a
have
lot.
looked in the abstract, it's a lot. It's more than 65,000 women would need to have desogestrel for one person who would need surgery for meningioma. And if you look at use for 5 years, about 17,000 women will have to use it for 5 years of desogestrel to then get the one person who needs surgery for meningioma. So overall risks, again, are very, very, very tiny here.
Yeah, very, very tiny. Is there a particular group then of people, if we're thinking then, well, why bother talking about this if the risks are so low? Are there particular people perhaps that if you're a patient or a doctor and you think, okay, this person has a family history, or are there a particular group of people who might be more susceptible that you think, oh, hang on a second, maybe I'll use something different?
So not really, except for a few pointers. So most of the risks for meningioma are age and being a female. But you could look at a few pointers. For example, the limitations of this study is they did not have a lot of data in terms of whether these patients had previous irradiation, what was the ethnicity-related risk in this particular group. So you could argue that previous exposure to radiation could increase somebody's risk of tumor. So if you have women who've had meningioma in the past, who have history of it, or have meningioma now diagnosed while they are taking the pill, or have history of irradiation to the brain in the past, those will be women where you might want to say desogestrel is something certainly you should stop using, or try and not use desogestrel containing products. And that goes for all those progestogens. So the cyproterone acetate, pills like Zoili, which contain some of these progestogens, Provera or desogestrel now, all these either don't use if there is history of meningioma, or stop if somebody develops meningioma. That's the strong message coming out here. But for all the others, there's no need to panic with progestogen only sort of pills, because remember, the risks are extremely, extremely small. It's only an association. It's not a causality, because this is an observational study. And the benefits of contraception with the POP will far, far outweigh these minuscule risks we are discussing. So that needs to be in the context.
Yes, absolutely. I guess also with people with endometriosis and stuff, there'd be a weighing up of risks and benefits in yeah.
Correct.
The interesting thing, I was just about to, the IUD, what did the route of delivery matter?
No, so again, they did a previous study, and this study, levonorgestrel in the form of IUD doesn't seem to be associated with an increased risk. And so that again is a safety signal there, that it doesn't seem to be increasing the risk like the desogestrel oral POP. And so important, you started saying, why are we discussing this in menopause? Yes, rightly so, because we do have women who are going through perimenopause who need contraception alongside HRT, and we often will offer them a progestogen-only pill, or they have Mirena, and that's because it's either as part of HRT or separate contraception with a combined HRT. We are trying to make sure that they're aware of all the risks of the POP when we counsel them, and then start them on the POP. So that needs to be factored in when you're sitting in front of the patient and counseling them.
Yes, exactly. Brilliant. Is there anything else we need to know about that one?
No, I think there are a few nitty-gritties there. So every paper we discuss, we'll put on the slide. You can actually look these up on Google. Many are open access. Others may need access by paying, or if you're through an institution, you can go through there. But if you want the details, they're all tabulated. There are supplements, and you can look it up on the internet.
And if I get my act together, I will put the links in the notes after this as well, so people can actually link on to those studies and have a look at them, or at least have a look at the abstracts, as much as I could get to look at, which isn't always all of them. I shall move on then to the next one, and the thing I really love about this is being a lovely person with dyslexia. To be able to pronounce these words nearly kills me, but that's okay. That's not right. We'll get through that. So the second one you've chosen has this is always controversial, isn't it? When it comes to HRT or non-HRT options for controlling vasomotor symptoms, this tends to get up some people's noses, but it is a viable and very, very important option for people. So this is a second one of these non-hormonal drugs for vasomotor symptoms called, I know I'll give this my best shot, Elinzanetant.
Elinzanetant.
There you go, for vasomotor, for endocrine therapy for breast cancer, because this was they were hoping that these drugs were going to be sort of the great white hope for people with breast cancer, weren't they? So what have they found? The other one being Elinzanetant, and then this one. What is this study telling us?
Good. So the background, as you rightly said, we had Vasomotor NK3 receptor antagonist, which was licensed in the UK last year. And this was around beginning of 2024. We have been able to use it in the private sector in UK. Most of our patients have seen benefits in reduction of vasomotor symptoms. Personally, in my practice, I haven't come across any major side effects or liver issues so far. But it's important to note that for Vasomotor, there is liver monitoring required, because if the liver enzymes go above a certain limit, then the drug may not be for you. You might have to stop it until the liver enzymes then return back to normal. So the good bit is, again, now we have another addition to that group of drugs, which is Elinzanetant. This is an NK3, NK1 receptor antagonist. It has completed trials, and the different sort of distinguishing thing here is that this was a trial specifically in women who've had breast cancer or trying to prevent breast cancer. And it's for estrogen receptor positive breast cancer who are taking the adjuvant therapy, whether it's tamoxifen, whether it's aromatase inhibitors, without the GnRH injections or the agonist. So this is a population, which is a niche population, often can't use HRT because estrogen receptor positivity is generally a contraindication for use of hormones and increasing the recurrence of cancer coming back. And so this group usually needs non-hormonal options, whether it's lifestyle, whether it's CBT, whether it's non-hormonal off-label drugs like SSRI, antidepressant, gabapentin, clonidine. Now you have the NK3 and the NK1, which receptor blockers, which are a welcome addition to that group. So nitty-gritties of the study. This is a phase 3 RCT randomized trial. It was covering women between the age of 18 to 70. These women had moderate to severe vasomotor symptom. That means flushes, sweats that basically stop you having your day-to-day work going on well. So they're limiting your quality of life. The endocrine therapy that was being given for hormone receptor positive cancer, as I said, could be aromatase inhibitors, tamoxifen, GnRH. Only one participant was taking it for prevention as such. Others were cases of breast cancer. And the two groups, you had the intervention group and the placebo group. The intervention was 120 milligrams of Elinzanetant orally daily. And the placebo was getting, of course, the placebo to kind of have a randomization. How many did we have? We had a very decent number, 316 in the group that received Elinzanetant, and about 158 women who were kind of matched placebo group. And for 12 weeks, they were receiving this two-tier treatment, one group with the Elinzanetant, other with the placebo. After 12 weeks, they all got the intervention. They all got Elinzanetant until 40 weeks. So that's about 52 weeks of the study. So 1 year of data. And again, how much was the reduction? Yes, there was statistically significant reduction. So both groups started with about 11 VMS episodes a day. And you could see that by the end of week 12, a reduction of about 8 less VMS episodes for the Elinzanetant group, while the placebo group had about -3, -4, 3 to 4 less episodes of the VMS. And the effect started very early, within 1 week, like it happens with Vasomotor, and it continued right through to the 52 weeks. So there was sustained efficacy until the end of the trial. Interestingly, 90% of women who were then offered a 2-year extension have apparently taken it. They would like to continue with the medication. So that again suggests that the drug was definitely efficacious, giving quality of life by suppressing the vasomotor symptoms. Any side effects? Always we talk about side effects: headaches, fatigue, somnolence, dizziness. Serious adverse events related to drug, less than 2.5% in the study group, about less than 1% in the placebo group. There wasn't a substantial hepatotoxicity signal with Elinzanetant. So again, this could be a useful option once it's approved alongside Vasomotor. Both drugs will be a very useful non-hormonal option for women who don't want to take HRT or can't take HRT or have side effects from HRT, or as a standalone option if they want to try it first.
Yep.
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 Any questions on that from you?
From me, I mean, I suppose there will be people who will say, this study was funded by the manufacturer, which of course it was. But to study something for a year is quite unusual, and it is quite a long and detailed study, isn't it?
In any field of medicine, pharmaceutical companies will develop new molecules. NK3 receptors have been developed with research over years. If you heard a lecture from Professor Komlinos from Imperial College, their team has been developing NK3 receptors for the past many, many decades. A lot of research has gone into finding out what these candy neurons in hypothalamus do. How do we then attribute hot flushes to them? What happens to the signals when you block the receptors? And it has taken years for pharma companies to develop this medication. And so, of course, it will be pharma companies who run trials for new medication. At the end of it, we hope that we get an option that is useful for patients. We explain these are the benefits, these are the risks and the side effects. And then it's for the patient to choose which option they would like to go with. And every patient will have a different option that suits them.
Yeah, there were some patients in there that had a recurrence of their breast cancers. What do we know about the rate of recurrence and the role of a drug like this, perhaps, in recurrence?
Again, as I said, this trial was specifically not meant to look at the recurrence rates or to look at the cancer recurrence or the survival. You need much more better designed, longer duration studies with different sort of inclusion-exclusion criteria, following them up over a longer time to comment on any recurrence rates or survival benefits or disadvantages. So really, we're looking at efficacy here and the short-term side effects and safety. And so we'll need much more data in future for real life to comment on whether there is any attribution of any recurrence to any of these medication. So far, though, the signal doesn't appear to be that it increases any cancer risk.
Yeah, because it didn't give an awful lot of detail of how far out these people were from when they just finished their breast cancer treatment.
Correct.
So it was a little bit on the vague side when it came to that, but good news for those who are seeking options and don't have any, which is always a nice thing to take home. Is there anybody, if you had a patient in front of you, is there anybody that you would exclude from using these?
No, so again, I think with most of these medications, there is often a SMP and a license that's been issued based on the safety and the efficacy studies. There are certain contraindications, for example, if there is hypersensitivity with certain medications which activate cytochrome pathways, you shouldn't be using it. Suspected pregnancy, non-pregnancy, these will be sort of product license contraindications. In many other situations, it's all about benefit risk, and it's about monitoring liver enzymes if you're using Vasomotor. But other than that, nothing comes to mind where specifically one would single out a patient that you can't use this in.
Okie dokie. All right. Next one. Common mental health diagnosis arising from or coinciding with menopausal transition and prescribing of SSRIs and SNRIs and other psychotropic medications coming from the Journal of Affective Disorders. And also, I think, I can't remember when it came out, or where is it? November last year. So another relatively recent one. What did this one tell us?
So I was involved with this project, and Dana, who was sort of leading this project, has done an excellent job. It needed a lot of sort of work in terms of getting this data and analyzing it. So kudos to her for doing that. But this is again a population-based descriptive study. It's about looking at a UK primary care database. You're looking at patients' records over about 10, 11 years between 2010 to 2021. You're focusing on women equal to or above the age of 45. You're focusing on men equal to above the age of 45. Now, what you're really trying to find out is what is the rate of common mental health diagnosis, and they're grouped into anxiety and depressive disorders. What's the common prescription that's issued in the first year whenever somebody has a common mental health diagnosis? Is there a difference in the rates of what prescriptions are given in terms of men and women? And what it did find was that if you look at the rate of diagnosing common mental health disorders, especially between 45 to 54, that's typically when perimenopause, menopause will happen for majority of individuals. The rates are higher in women, so 1.68 to 1.69 per 100 person years at risk in women, and about 0.9, 1.2 for anxiety and depression in men. So what it simply says is much higher in women as compared to men, significant statistically. And again, what was the most common prescription? It was SSRI, SNRI, the antidepressant group of medication. Again, prescribed about 50 per 100 women and 40 per 100 men. And this was all happening between 2010 to 2021. And the interesting thing to note is that the SSRI, SNRI prescribing has increased in those 10, 11 years. So that's a trend you're seeing here, is that the prescriptions have increased. Of course, the study has limitations. Remember, it's a huge observational sort of study describing the database information. And whenever you look for database information, what you collect is dependent on what variables you can see in there. The database is, no database is perfect. It will have missing things. There'll be recall problems. There'll be prescription problems. So it's never 100% gold proof or standard. But there are limitations on how, for example, when the menopause happened for these women, always onset of menopause wasn't recorded in the database. They may have been given hormones for another reason. So the reason why some of these were prescribed hormone therapy was not clear in the study. There were many confounders which couldn't be adjusted, like financial status, educational status, marital status, physical activity, and all these could impact common mental health diagnosis. So we're not just saying that this is 100% perimenopause that was causing it. There may have been other reasons why these women between 45 to 54 were going through mental health diagnosis. And then, of course, accurate indications for hormone prescriptions were not clear. But what it does show you is that the rates of depression, anxiety increase, and that seems to be at the same time that most women are going through perimenopause, menopause. And there are a number of studies now which link the two. It does appear that the lower mood, the depressive symptoms, anxiety, they are part of menopausal transition for many women. SSRI, SNRIs have been traditionally the first to go medication in the primary care for this reason. But since the NICE guidelines have come in, we should be changing our approach. And unless there is clinical depression, there is some event, there is some past history pointing towards depression, if this is in association with perimenopausal changes to periods or symptoms in women, then you're much more likely to succeed giving menopause hormone therapy or hormone replacement therapy as your first line. You should not use SSRI, SNRI as first line in these women when the diagnosis coincides with perimenopausal changes. And that's again what's the conclusion of NICE, and that's what we see in sort of day-to-day reality. So that's what the study adds in terms of where we are. And the only last point before we discuss it is, remember, SSRI, SNRIs have their downsides. They can cause lots of minor side effects, but they do have some implication. For example, they can make you lose bone density. They can increase risk of osteopenia. There have been some reports, not very sort of conclusive, that they can also affect some of the cardiovascular health and they can cause some symptoms. And so therefore, it's a balance between SSRI, HRT prescribing that you have to get right as a physician when you see women between 45 and 60 presenting with mental health diagnosis.
Yeah, I mean, it's sort of when I was reading that, I was thinking, my God, this screams out for the fact that we really do need a tool in general practice, or for women as well, that really does help us differentiate what is a hormonal depression and what isn't a hormonal depression. Because in 10 minutes, I guess it is very, very hard to tell. And I do feel very, very sorry for practitioners when somebody walks in and says, my life is awful. I no longer feel like I'm all of them. You can see them ticking it off and going, and once if they mention suicidal ideation, you're probably not going to take the risk. But
yes, I think we need to be educating health professionals better and providing them with better tools so that they can at least differentiate between diagnosis related to perimenopause versus what would be unlikely to be dictated by the changes that are happening in perimenopause. I think most primary care physicians and most specialists will be able to do this, but there will be some patients where challenges will remain in making the diagnosis at the first go. And I often say in that situation, you can even sometimes offer HRT as a trial when you're more inclined to say that this is likely hormones. And if the HRT is not able to deal with the situation, then you switch back to SSRIs, SNRIs, CBT, counseling, many other therapies which are available. So sometimes it may be very difficult to get the right diagnosis first time around because life is complex. There are so many factors. But keep HRT at the back of your mind. I think many of those 50 per 100 women we are seeing in the study getting SSRIs as a first line, many of those could potentially have had HRT as a first line. Those were highlighted in the paper. Certainly, a big proportion, I think, may have been missed to be offered HRT and been given SSRI here.
Yeah, because it was interesting in there as well. They were saying that the prescribing rate did go up in that particular peri group, really, wasn't that was the highest rate in that 45 to 54-year-old age group, which is and if the rate overall has gone up and we've seen the HRT rate going up as well, I mean, are there other things at play here? I mean, do we actually have more people having depression, clinical depression?
So there are so many factors which will be the confounders here. As I said, there was not information to match for all the confounders here, but you could argue that there are many other factors with modern life that are increasing in the background, which is contributing to some of the trends we are seeing in the paper. There's no denying that.
Yeah. I mean, we've had COVID, we've had all sorts of things that, you know, upset people's lives in the recent history. So, yes. Anything else? Any take-home message then, if you were for either patients or doctors on that one?
So again, the take-home message will be similar to what NICE says. If somebody is having onset of anxiety, low mood, depressive symptoms, coinciding especially with their perimenopause journey, menopause, think of HRT as first option rather than SSRIs or SNRI. That's the message here.
That's the message there. All right. Now the next one, this one, I've got a question for you about the Elinzanetant again, but I'll hold that to the end. Right. Here we go. Now, this is one that I should definitely have known about as well, but did not. Early menopause and premature ovarian insufficiency may increase the risk of sarcopenia. Systematic review and meta-analysis, which has just come out as well. I can't see the date. When was this one, Vikram? I can't see it.
I think
September.
Don't remember from the top of my mind. You'll have to check the date.
September. Yeah, I think it says September 2023.
Yeah.
My glasses don't work well enough, clearly. Right. Now, early menopause and premature ovarian insufficiency. So people who go through menopause between sort of 40 and 44, or those premature POI under the age of 40. What did they look at and what did they find?
So this is a short one. This is a clear and simple paper as compared to the others. Basically, what it's trying to see is, do women who go through either POI or early menopause below 45, what happens to their muscles? Do they have an increased risk of having muscle loss, so low muscle mass? And also, what about the muscle strength? And it does show. So this looked at about 6 studies. So when they tried to do a systematic review here, tried to do a meta-analysis, they tried to go through about 1,000 papers with the initial search. Then they selected about 22. Then they had to throw others out. And eventually 6 studies were included with the inclusion-exclusion criteria. Then this covered more than 18,000 women, postmenopausal women. And they were interested in looking at muscle mass below the age of 45 and below 40 menopause, comparing it to women who are having menopause after 45. And in the early menopause group, they did find they had lower muscle mass, lower muscle strength. In POI women, again, lower muscle strength and mass. So again, this is important finding. The reason to talk about this is we talk so much in the POI and the early menopause group about benefits of HRT for bone, for heart, for cognitive decline, for metabolic factors, but we don't specifically mention muscle. We just keep talking about bone. And This often gets left out because the two are interrelated. The muscles are really, really an important component of the body. They're going to dictate your metabolic health. They're going to dictate your cardiovascular health. The bones often rely on muscle strength. And so any bone fractures, osteopenia will worsen if your muscles are not strong. Your overall respiratory function, your ability to function on a day-to-day basis, quality of life, all is ingrained with your muscles. And that's an important part of the day-to-day functioning. So again, it does mean that we have to be proactive with intervention when we diagnose POI or early menopause, not just talk about the bones, the vitamin D, the calcium in food, the weight-bearing exercise, but also the exercises for muscle, good protein intake. Those will be the interventions to highlight here, trying to do resistance, trying to do strength exercises alongside weight-bearing exercises for the bone. Because if you're not going to take care of muscles, you're going to, again, worsen the long-term outcomes with many of the parameters we are looking at. And that is the key message, this short paper, to say, talk about muscles whenever we talk about bones.
Yeah. Now, there's a bunch of people who will say estrogen has absolutely nothing to do with sarcopenia, and you're barking up the wrong tree. But this obviously seems to indicate that for people who go through menopause much earlier, there is a relationship.
Well, it does suggest, biological plausibility, it does look like there is definite role for sex hormones here. Estrogen certainly helps bone and muscle, really, you can't separate them because they're so intertwined with each other's health. So really, this suggests that the fact that they've lost estrogen early in life, these women are already showing signs of decline in their muscle mass. Definitely, HRT will be one of the intervention alongside the lifestyle, which will be certainly worth considering, not just for bone and heart, but also to help with the muscle maintenance. So along with lifestyle, HRT has a major role in anybody under the age of 45.
Now, you would expect that most of the POI people on this would have been on HRT. So does that then indicate that for people who go through POI, that they should have perhaps higher doses of HRT, or does it make any difference?
No, so it doesn't make clear through the paper. When I tried to read through it, it doesn't really make that clear. And so I think we probably have limitation for this particular paper in terms of we don't have much data on the use of HRT or the type of HRT that would have been prescribed. So this is looking at association between the age and the likelihood of having low muscle mass without really dissecting into how many were on HRT, what type of HRT, and whether they had any lifestyle interventions, how many of them did or did not have. It's not very clearly coming out from the data.
Okay, so we need another study then that looks at what people are actually on and what their muscles and bones are doing at the same time.
Yes, so again, the call for research specifically in the muscle setting, focusing on muscle mass going forward in women who take HRT following POI, early menopause. It'll be a little bit difficult to control because you're not going to deny HRT to somebody just for the sake of study. But again, for some reasons, if somebody cannot take HRT, then that would be a comparison group to follow up.
Yeah, exactly. God, we need so much research everywhere, really, don't we? It just never stops. It never stops. It's a never-ending need. All right, and this one rings home. Because and actually, I put this to a couple of dermatologists yesterday who said we never consider HRT in this because there are so many other confounding variables when it comes to skin cancers. But this is an interesting one, looking at the effect of menopausal hormone therapy on the risk of melanoma and keratinocyte skin cancers, which are your BCCs and SCCs, which I'm covered in, a systemic review and meta-analysis of observational studies. So I did not know that there was a hormonal component to skin cancers. What's going on?
So again, the study is not very new. It was published a year or two ago. But the main reason to highlight it is just to know that there is so much confounding, conflicting data on this in literature. So there has been a long time talk about whether hormones contribute to an increased risk of melanoma, whether hormones contribute to increased risk of skin cancers like basal cell carcinoma. And over the years that this has been studied and addressed, general consensus is it does not. So one could still consider hormone therapy after having had melanoma or after having had basal cell carcinoma. But again, there time and again you get papers which often analyze certain studies, put them together, and come up with conclusions like this, where you say there could be a signal here. Estrogen could bring on melanoma. Estrogen could feed or make somebody more susceptible to getting a melanoma, or a combined therapy could make somebody susceptible to melanoma. So I'll tell you what this paper says first. The findings are conflicting with the research previously. But what this paper basically says is that HRT use could increase risk of melanoma. The specific types they say is something called superficial spreading melanoma, and there is LLMM, which is another histological type, lentigo maligna. And then, of course, estrogen therapy alone or estrogen progesterone combined HRT could increase risk of the melanoma in current users, people who are using it at the time. And estrogen only HRT could increase risk of basal cell carcinoma in current users, especially if they've used HRT for more than 5 years. That's what this paper comes to a conclusion after including many different studies and trying to get a conclusion together. The problem, though, is that it's observational data. The selection criteria depends on which studies you include. There's always a recall bias whenever you do observational data. Many papers previously have addressed the issue of whether oral contraceptives, HRT, or fertility drugs cause increase in melanoma or skin cancer risk, and they all concluded it does not. So there's strong evidence that actually this may not be a true conclusion. However, the clinical implication is keep this in mind. We need to continue looking at research like this in future, because it often gets undermined whenever there is a consensus that's been built up saying there's absolutely no effect. And so in future, it will be really nice to do analysis of bigger, larger number of patients, including more stringent inclusion-exclusion criteria, to know, is there a signal of estrogen which may, for subset of women, influence whether they get melanoma, slightly increases the risk? Is there a signal that this should be avoided if somebody has had a skin cancer or melanoma? In a subset of patients, should we not be giving HRT? Right now, we can't conclude, so we will still offer it based on the standard HRT recommendation. It doesn't seem to be a contraindication. Benefits risk discussion will be that benefits outweigh risk. But in future, something to remember that there may be some signal here which may become clearer in future for us, and that will be important to keep in mind.
When I was reading it, I was kind of thinking, okay, there is, age is a confounding factor,
Yes.
and it didn't really make clear from memory, maybe I missed this or I've just forgotten, who the demographic was that they were actually looking at. Now, I would assume that most people who are on HRT are generally white middle-class women who would have a greater, we're older and we're white, so we've got a greater risk factor of getting a melanoma in the first place. So how good a study do you think it?
No, it's not a good study, because again, all those studies which they've included as part of their systematic review themselves have lots of deficiencies, whether it's confounding factor matching, their exposure to the environment, other risk factors for skin cancer, the age, the ethnicity, the geography. Many of these studies lack the basic sort of data sets. Also, in terms of patients remembering their own diagnosis, remembering what exposure to any of these hormone therapies, it is all based on recall, and of course you can't rely on that. So again, many of the studies inherently have their own deficiencies. When you put them together, of course, the heterogeneity makes conclusions very difficult. But keep in mind that there will be more research on this in future, and so it's something like a trend to watch out for in case we have to change conclusions in future.
Fair enough. All right. Now on to the last and possibly most controversial one. Breast cancer risk in younger women may be influenced by hormone replacement therapy or hormone therapy, which came out in June, and this is the press release to it. I don't know why I couldn't find the actual study, but it was, again, this is one of these ones that makes everybody go, oh my God, HRT causes cancer. But what did they really find, and what were they saying?
Okay, so let me look at my notes. So this was recent. So this was 2025, and it's a pooled cohort analysis. covering studies and women across America, Europe, Asia, Australia. Huge numbers, included about 450,000 plus women, all under the age of 55. And again, you're looking at age groups between 16 to 54 with a mean age of about 42. That was the mean age of the participants in the study. 8,455 women had developed a young onset, early onset breast cancer. That was about 2% of the cohort. And the investigators were trying to find out how many of them had used HRT, whether it was estrogen only or estrogen progesterone combination, and what was the chance that the HRT could have influenced their risk of cancer happening. So that was mainly the study about. And it's a very good study because we often talk about late onset breast cancer. We have lots of data on women after menopause being diagnosed with breast cancer. This perimenopausal age group, often under the age of, say, 50, 45 to 50 or 50, 55, often this one doesn't get specific analysis or studies done. So it was useful to do the analysis. Now, again, what did they find? So they found that in non-users in this population under the age of 55, the cumulative risk of breast cancer was about 4.1%. And if these women had taken estrogen-only HRT, then the cumulative risk dropped, while if they had taken estrogen progesterone HRT, the risk went up. Overall, though, they found that HRT of any type was not associated with an increased risk. So if you combine the estrogen and the estrogen progesterone groups together, estrogen only and the combined, overall there was no association with HRT causing increased risk. But if you separate them out, estrogen seemed to decrease the risk by about 14%. And the estrogen progesterone combined therapy seemed to slightly increase the risk between 10 to 18%. And of course, most of the progestogens were synthetic.
It
So
sounds
here it's
like a very big risk, but in terms of it was actually not
no.
large numbers, wasn't it?
Correct. So again, these numbers would be kind of in keeping with the standard numbers we quote. For example, 5 in 1,000 or 10 in 1,000 extra risk of breast cancer with estrogen progesterone combined therapy. So don't go by just the percentages. It's the reduction or the extra percentage risk. Go by the numbers, which will be around kind of in keeping with the studies which we already know. But interestingly, the combined estrogen progesterone therapy, which slightly increased the risk, was mainly after 2 years of use, and it kind of increased the risk of tumors which were triple receptor negative and estrogen receptor negative tumors. So there was a little bit of association seen with those type of tumors as compared to estrogen receptor positive tumors. So the signal here in the study is estrogen-only HRT, when it was used in these women, was associated with a reduced risk. Estrogen progesterone slightly increased the risk. And most of those progestrogens would be synthetic here. And so that's the signal that comes out from the paper.
And we would, though, expect in some ways that those, especially who are triple receptor, that they would probably be at a higher, I'm guessing here, so tell me if I'm completely wrong, but would they not be at higher risk of a recurrence anyway?
Why? From this particular cohort?
Well, just generally, if you've probably got a higher risk.
This study was not looking at the recurrence, though. This is just looking at association of out of those 8,000 women, how many developed cancer. And if they were using HRT, say, which is about, say, 8,000 plus women, about of them, 15% were using HRT. Were they using an estrogen HRT, and were they using? So it was looking at the incidence diagnosis rather than recurrence there.
Oh, okay, sorry. And but for most people under the age of 39 or so to be using HRT, there would have been some sort of, perhaps, apart from POI, a surgical reason. So are they at a higher at-risk group in general?
So this is not like somebody having POI and taking HRT. This is basically somebody who is using HRT in the perimenopause group, using HRT after a hysterectomy, after a oophorectomy. Yes. So this group is basically women who've had menopause because of, say, oophorectomy or hysterectomy and then had a menopause, perimenopausal women using HRT who may still be having their periods. So it's sort of a bigger mixed group here. who have been using HRT, and then you're trying to find out what their risk is, rather than those who are completely postmenopausal and then having their HRT.
Yeah. So
After the age of 55.
Did they make that kind of clear who may have had a hysterectomy for various?
Yes, I mean, if you look at the details in the tables in the supplements, yes, there's a lot of data and that's been provided with the original publication, and so you would have to actually delve into the tables. I had a brief look at it before making a summary, but it does give you which were the women who had a hysterectomy, estrogen only HRT, and of course the combined HRT would be for the one who had not had a hysterectomy. And the perimenopausal group and the surgical menopause. Yes, the details are all there in the tables and the supplements.
Yeah. So is there a take-home message out of all of that then?
Well, I think one thing that majority, again, people who will like to give sort of highlights of the study missed is that they were talking about the risk, but not the good news coming out of it, is that this agrees with the WHI findings. We always said that estrogen doesn't increase the risk or sometimes reduces the risk of breast cancer. That's been the traditional sort of saying we've been saying based on WHI for a long time. But the NICE guidelines did not include data on the WHI. They chose to go by the observational data, which says that estrogen on its own does increase the risk, not as much as the combined HRT, estrogen progesterone, but nevertheless, it does increase the risk. That was the observational data that they rely on from the Lancet meta-analysis. And so this finding of, again, in this particular younger women below 55 having breast cancer, estrogen being associated with a reduced risk, again, agrees with the WHI data. So we think that estrogen here, not the main culprit. It's the combination HRT, the progestogen, just like in the WHI study, that seems to give that additional 5 or 10 in 1,000 risk of breast cancer as compared to the estrogen.
All right.
So it ties in well with the information we already know.
Excellent. And does that then give comfort? Because we know that people get very upset with this in the end and they sort of think, oh my God, I made a dreadful mistake and I should never have been taking this in the first place. Or their practitioners might think, oh my God, this is too risky for this group. Does this show any, is there any change of practice here? Should anybody be worried about anything at all, given you're saying it's in line with what we already know?
So no, some changes in terms of counseling. For example, so you would do the same counseling for majority of women. If women go through POI, premature menopause or early menopause, that's below the age of 40 or below the age of 45, you would say to them that HRT does not increase your risk of breast cancer over and above what the background risk is. And you can safely consider HRT, whether it's estrogen only or combined HRT, until the age of 50 or 51, which is the natural age of menopause. The HRT won't add any risk. After the age of 50-51, the longer you stay on HRT, risk will apply. So that's when the breast cancer risks needs to be discussed. This is for women with POI or early menopause. This is standard practice. That will still stay the same. What about women who are starting HRT after the age of 45? So they've not gone through early menopause. They've not gone through POI. They're now in that perimenopause, early menopause stage, starting HRT early in life. Then you go through the benefits for quality of life, for bone, for heart, for metabolic factors. And then you say the risks will be, if you use estrogen only, unlikely to increase your risk. And actually, as more and more evidence is coming forward, your risk may be lower on estrogen only, but that's only possible if you've had a hysterectomy, of course. But if you're taking estrogen, progestogen combined HRT, there is a slight increase in risk, which amounts to about 5 to 10 in 1,000 over first 5 years, and then it doubles thereafter every 5 or 10 years. It will depend on the progestogen. Synthetic progestogens are known to be the main risk here. Natural micronized progesterone, dydrogesterone may have a lower risk. That's based on observational data. So nothing will really starkly change, but it confirms that estrogen only is unlikely to increase risk. Estrogen progestogen is the one that's the culprit here.
Okie dokie. All right. Now let me go back to the vasomotor symptoms, and the question was, how realistic is it how realistic are these drugs to come into clinic soon for a patient with breast cancer, considering the lack of data of recurrence? So basically, I think what she's trying to say there is basically in the end is if we don't know about the recurrence rate, is it actually safe to give these to patients? And while you're answering that, I'm just going to do what I forgot to do over here.
You would have to wait a long time to get real life evidence with use of these drugs for 3, 4, 5 years to really know the long-term effects of these medications. They've really just been developed in the last year or two. They've completed 1 year of trial. That's all the data we have. So at the moment, if somebody chooses to take Elinzanetant or Vasomotor, it's a discussion saying we have 1 year's worth of data. We know the benefits and side effects so far. And so therefore, if you're going to consider this as a non-hormonal treatment, it's based on the discussion between the doctor and the woman or the patient. If benefits outweigh risk, whatever little we know, if the vasomotor symptoms are really bad and having a terrible impact on quality of life, number of women will choose to take it and then continue on the medication. Others may say, I cannot put myself in a position when I don't know what's going to be the long-term data. And they may say, I don't want to consider this an option. I'll wait for a few more years before considering. Everybody is different. We already have women who have completed active treatment for, say, breast cancer, who are now using Vasomotor. And so they will continue if they feel the benefits outweigh the risk. Others who may be more apprehensive, want to wait for more long-term data, may have to wait longer, because at the moment in the UK, we only have it in the private sector, so numbers will be relatively small. When it hopefully gets approved on the NHS, maybe end of this year or next year, we might have more bigger numbers where we can find out real-world outcomes. So we have to wait for that.
Okay. So in general, individual risk and good informed consent.
Yes.
Yay. Brilliant. All right. Are we done? Do we think we've covered these?
I think we have. I think we did well to get through in 50 minutes.
I think we did actually very, very well indeed. You must be exhausted because your brain's peaked there, and I just have to get the tongue around big words.
Well, I hope we did justice. As I said, we can't go through every little aspect, every detail. And again, the notes I made was my impression of how the studies look. There will be people who will dissect the data differently. There are always different opinions between researchers, scientists, clinicians. And feel free again to come back to us if you have any more data on these studies, if there are any other relevant publications we should be looking at based on these studies. Anything that you want to criticize, anything that you want to agree, will be more than open for feedback. So every time we choose new papers, every time we look at new papers, it's really to kind of stimulate scientific discussion so that every time we do a new round, we do it better and better. That's the aim. And hopefully you'll find this useful.
And not just for, not scientific discussion, not just within the scientific or medical community, but also to make sure that patients really understand and they've got a plain English sort of summary that they can go, oh God, now I know what that means.
Good.
Yes. All right, brilliant. Thank you for that. So I will put the links to this once it's saved, and I shall end this now. I will use Dr. Alex. We will look at that one next one. Someone's asking if we can do vaginal estrogen with aromatase inhibitors in the future, which we definitely can. And I'm sorry that dropped out before. I will end that there, and now I will end this over here as well. I'm ending everything anyway. And thank you again, Vikram, and I'll talk to you soon.
Catch up soon. Bye-bye. Thank you, everyone who joined. Bye-bye.